on that note, good afternoon, sir. So we're back in Scotland. I'm back in 3 layers again. The last time I saw you, it was beautiful sunny Milan. It was the EASL Congress, and I have tons and tons of questions to ask you. But I'm going to say, first of all, welcome. Thank you so much for joining us. How was your EASL?
Yes, EASL was it was good. It was a very good time for PBC in particular, and those people who are interested in developments about rare liver conditions such as PBC. I was only there for a short time, as Robert knows, but some others may not, because I had some passport issues at border control. So I had to get an urgent passport renewal because of it having less than 3 months left on my passport. So despite the UK allowing me to travel just the week prior, last week was slightly problematic, but thankfully things were resolved, and I was able to attend and perform my responsibilities.
I did not know. So I'm quite impressed at how relaxed you look by the time I saw you then. So
that's okay. You can't stress about everything in life.
So. You got in and out. Right, okay, got lots and lots of questions coming in. We're going to talk about second-line therapies and all things around that as well.
Yeah.
Thursday, the 13th of June, 2024. There's a campaign around the world to build awareness of steatotic liver disease.
Yeah.
So could you just tell a little about steatotic liver disease and PBC, and just kind of where they intersect and what the overlaps are? Or what
absolutely. So steatotic liver disease, the word steatotic means fat. Now that's quite a stigmatizing word, quite a derogatory word for many people. But steatotic liver disease used to be called by another name, fatty liver disease, so fat deposition on the liver. And it's now the leading cause of abnormal liver tests, chronic liver problems in the Western world. It's overtaken viral disease, overtaken alcohol, overtaken PBC for sure, and other autoimmune conditions. And it occurs in about 1 in 3 adults in the Western population. So 1 in 3 people in the United Kingdom will have some element of steatotic liver disease, fatty liver disease. And it's a direct reflection of lifestyle for most people. So we are no longer hunter-gatherers. We now, after work, before work, during work, in some cases, able to go to a place that will sell food, all types of food in one location, often with certain additives, for example, to keep it fresh. And the prime example is if you go to Tesco's or Sainsbury's, you can buy your bread there, your greens there, some people can get ready meals, there are all sorts. In the 80s, that was a rarity. Whilst there were supermarkets in existence, you would have to go to a butcher or a greengrocer or a fishmonger or a baker where there were little additives inside foods. And it was very unusual, uncommon to see steatotic liver disease. Now it is the norm. As I mentioned, 1 in 3 people have it. And it is a big problem. We know that people who've got steatotic liver disease have a higher risk of developing strokes, heart attacks, and those types of complications, diabetes, if not already, in later life compared to people without steatotic liver diseases. And the way that we handle it principally is lifestyle related, so minimizing consumption of ultra-processed foods. As if Colette was here, we will talk about movement as medicine, but engaging in regular aerobic exercises about 5 times a week to the point where you get out of breath and sweaty 30, 40 minutes at a time, and trying to cut out things that are highly processed, like bread, pasta, potatoes in unhealthy forms. So for example, store-bought Kingsmill Hovis bread, even if it's wholemeal, cutting out chips, cutting out store-bought pastas, that sort of thing, from about 2 or 3 meals in the day without overcompensating at remaining times. That is a key lifestyle thing. And for people who've got evidence of damage to the point where they have scarring in their liver, fibrosis in their liver, inflammation, there are a whole swathe of new medications that people can take if they are not able to lose weight or tackle other risk factors associated with steatotic liver disease, like high blood pressure, high cholesterol, diabetes, etc., to try to reduce weight and improve their liver health. But whilst those drugs are available, they are not definitely not the first line, and not my preferred option to try and deal with steatotic liver disease. And before I stop ranting on about it, I thought I just wanted to talk. You asked a question about the overlap with PBC. Now, if 1 in 3 people in the Western world have it, it's not unusual now for us to see people with PBC who have an element of steatotic liver disease. They are not related directly, but if you have risk factors such as having an increased body weight, diabetes, being inactive, consuming ultra-processed foods, for example, high blood pressure, high cholesterol, those things can also lead to steatotic liver disease, even if you have PBC and you don't want 2 fists punching your liver. We can control PBC for the vast majority of people with medicine, and that is not a lifestyle-driven disease at all. But when it comes to steatotic liver disease, that is the definition of a lifestyle-driven disease for most people. Some people have genetic risk factors without any of the things that I mentioned, but they're a minority. But for most people, it's lifestyle-driven. So minimizing that other fist punching your liver is important, particularly if you've got PBC or another liver disease as well.
Okay, perfect. That was a great answer. We might even snip that out and make that a standalone piece, if that's okay. Yeah. So thank you. Okay, so we did say today's going to be a second-line therapy special, and that's because of some of the exciting stuff that happened at EASL and then after EASL. Before we get on to second-line therapies, what should we know about first-line therapy in PBC? What does that look like?
So first-line therapy in PBC, if I divide into 2 parts regarding the medical, the medicine aspect of it, there is treatment towards slowing down the rate at which the liver disease may progress, or controlling it and stopping it progressing. And there is the symptom-directed treatment approach, which is different. And both of those should be considered first line in anybody and everybody with a PBC diagnosis. To make a PBC diagnosis, we need an antibody test in blood, an abnormal liver blood test with an elevated alkaline phosphatase in particular, and a liver biopsy. Any 2 of those 3 things are compatible with making a diagnosis of PBC. If somebody has normal liver tests despite having the antibody, that is insufficient, and those individuals don't require medical therapy per se, but they do require follow-up in some description. But to get to the answer, in people who have abnormal liver tests and a diagnosis of PBC, ursodeoxycholic acid is still the first line and the only therapy that we would consider first line for treatment of primary biliary cholangitis. And there is now a wealth of evidence that's taken decades to accumulate to show that it improves survival, mostly in people who normalize liver tests, but also in people who improve their liver tests to a certain threshold. People who take ursodeoxycholic acid live longer than non-treated individuals, and that is the first line. For people who are intolerant to urso, though, we would offer second-line therapies, which I'm sure we will come to discuss later on in the webinar this afternoon. But urso should be offered to anybody and everybody at the point of diagnosis. Symptom therapy is different. Ursodeoxycholic acid does not tend to address the main symptoms of PBC, such as itching, such as fatigue, such as brain fog. It might improve them in some individuals, but for most people, we would not say that urso is expected to treat their symptoms. For itching, first-line therapy can be offered in the form of cholestyramine, which is something that you take in powder form, either dissolved in liquid or sprinkled on food, and that tends to bind certain bile acids that your liver makes, and you then pass them out in stool. In parallel, another first-line treatment, at least in my practice, would be a medication called rifampicin, which is a type of antibiotic, but we don't give it because it's an antibiotic. We give it because it affects the way that the proteins that transport bile in the liver are expressed. And some people sort of would also go on to offer as a first-line anti-itch agent in the current day and age therapies such as bezafibrate, which I'm sure we'll come on to later for other reasons, therapies such as naltrexone or sertraline. Now, whilst we have different treatment algorithms, you start off here, if that doesn't work, you move here, then you move here. Often you have to tailor the anti-itch medication depending on what other things are going on in a person's life. So if somebody, for example, is experiencing itch with very poor sleep, and they also have symptoms of anxiety and depression, we might go to sertraline first, because that has certain antidepressive properties as well as being an anti-itch agent. And we would often give that as a first line in individuals. In people who are on certain medications that interact with rifampicin or bezafibrate, we might go to naltrexone or cholestyramine as a first line agent. So it's important to not think about anti-itch agents in a first, second, third line way, but more of an individualized approach. But first line therapy to stop disease progression or slow it down is always ursodeoxycholic acid.
Okay, perfect. Thank you. I appreciate that. So taking the symptom modification medicines and treatments and therapies to the side, ursodeoxycholic is the first line therapy. So now I think you're just old enough to remember the days of urso-then transplant. So in terms, what's changed recently, and what do we know about second line therapies, just in general terms first?
Sure. So all the therapies that we use to slow disease progression in PBC affect the way that bile acids are made, transported, and exit in the liver and exiting the body. They all work on that axis. And up until 2015-16, ursodeoxycholic acid was the first and only therapy licensed for the treatment of PBC. In 2015 and 16, there were very large clinical trials that were published, which showed that newer agents such as obeticholic acid, which is now standard practice, or Ocaliva is the trade name of the patented compound, that in addition to ursodeoxycholic acid for people who didn't respond to urso alone, were shown to improve blood tests which later translate to improved long-term survival without needing a liver transplant. So the treatment pathway changed, wherein people who responded to urso would continue on urso, and the definitions of response have changed over time. They become more and more stringent. But when people respond to urso, their symptoms were addressed. That's all they needed. People who did not respond to ursodeoxycholic acid were then offered obeticholic acid or Ocaliva as a second line therapy. In parallel, there was a body of data using a medication called bezafibrate, or a class of drug called fibrates, which have historically been used to treat high cholesterol. And when given to people with PBC who had high cholesterol in certain other countries, were shown to normalize or at least improve liver bloods. So we started as a community to explore these fibrates, in particular bezafibrate, purely for the treatment of PBC, ignoring what the cholesterol is, whether it's high or low was slightly less relevant. We gave it to people to treat their liver disease. And then a large clinical trial that was published in 2016, I believe, or thereabouts, by our colleagues in France, showed that bezafibrate, like urso plus Ocaliva, was shown to improve liver blood tests, normalize liver blood tests in a group of people, and that has now become standard of care in the UK and many other countries. Now, it is not what we call licensed for the treatment of PBC, because it was licensed for something else many decades ago, and its patent has run out. And to get a license, you need usually need a drug company to lobby regulators in every single country across the world to say, can you make it licensed for the treatment of PBC? And there is no pharmacological company that is lobbying for that to happen, because the medication is not expensive. It is very cheap, widely available, and there's no real need to do that if you know how to use a medication. So second line therapy up until now has consisted of treating people who are either intolerant to urso or who are non-responders to urso with one of those two compounds, Ocaliva or bezafibrate. And they both work equally well. They both work differently, slightly, on the bile acid pathway. Bezafibrate has the added advantage of helping to treat itch as well as improving liver blood tests. Obeticholic acid or Ocaliva has slightly more evidence in people with more advanced PBC, such as people who have cirrhosis, and in people who've got elevated ALT and AST values, which are other liver enzymes. So they both have found their home, and we've got years of experience now, sort of encroaching slowly upon decades of experience with these two new drugs. In EASL and in similar liver meetings in the last few years, there have been what we call next generation second-line therapies, which we'll come to talk about this afternoon, which have been shown to have, I wouldn't say even greater benefit, but at least the same degree of benefit to obeticholic acid and bezafibrate, even in people who have had those compounds and not responded to them before. And these compounds are sort of what the most of our discussion, I suspect, this afternoon will take. But at present, it's still obeticholic acid and bezafibrate for people who don't respond to URSO or who are intolerant to URSO.
All right, brilliant, thank you. So we're getting close to today. So we've gone through URSO, we've gone through OCA, and OCA has a completely different mechanism.
Yes.
We have bezafibrate that is unlicensed but has a different mechanism again. And then for the last year or so, there's been a lot of excitement about two second generation, what you guys call PPAR activists.
Yeah.
What does that mean?
So bezafibrate itself is what we would call a PPAR agonist. PPAR stands for a very long term peroxisome proliferator activated receptor, of which there are various different forms. There's an alpha form, a gamma form, a delta form, and they're expressed at various parts in the body, the muscles, the liver, the kidneys. And when it comes to the liver, being specific, the bezafibrate exerts this mechanism of action and improvement in patients with PBC through the PPAR isoforms that are expressed in the liver. And your liver will express different, not just one particular isoform of PPAR, but because your bezafibrate exerted its effect on all of the three, the next question was, well, what if we can target one particular or two particular isoforms of PPAR? So almost develop what we call a next generation bezafibrate of sorts, or a purified form. Now, one of the challenges with bezafibrate is it's a very good medication, but about 1 in 10 people or slightly more can experience a flare in liver blood tests. And it's difficult to predict that without monitoring them closely. So when we start people on it, we say it's with the intent of normalizing things, but these medications are handled by the liver, and we don't want it to improve things in one side and worsen things in the other. So that's why some of these newer agents were developed, to try and offset that complication. Similarly, some people with bezafibrate, we can notice a slight deterioration in kidney blood tests. It's uncommon. I've not had to stop somebody from bezafibrate in our program. We've got hundreds of people on it because of kidney problems, but we do see a slight increase in some of the blood tests. Sometimes it's transient, sometimes it's not, but it is reversible on stopping medication. And we have to think about that particular element of safety. And the third thing that bezafibrate can do in about, again, 5% of people, it's not, and I'm not needed to stop it in anybody because of it, it can cause some muscle pains or muscle aches in the first few days of starting. So the rationale to try and develop a purified, slightly more neater version of bezafibrate in effect was there. And certainly something that's licensed and gone through the formal licensing process. So elafibranor came out as a compound under clinical trial, and the other medication, which I'll talk about, is called seladelpar. So they've got very long names. I don't expect people to remember them, but just the concept that there are these newer agents. Now, when it comes to elafibranor, when it comes to seladelpar, importantly, they are not the same compound, and there is no head-to-head comparison between the two. So it is no point in asking anybody at this current stage which of the two drugs is better. People will have their own biases, their own impression, but there is no head-to-head of these newer agents, nor is there a head-to-head comparison with our existing agents, such as Ocaliva or bezafibrate. We've got people who haven't responded to those drugs, who have now started taking these new drugs in clinical trials, but there is no head-to-head comparison. But these sort of new drugs have been developed specifically for the treatment of PBC, work similarly to bezafibrate, but slightly neater in their preparation. For those scientists among you, elafibranor is what we would call a dual alpha delta PPAR agonist, and seladelpar is a pure PPAR delta, or what we call a delpar sort of agonist. So they work slightly differently to one another. And the long story short is both of these compounds have been shown to induce a very rapid reduction in various liver biochemical parameters associated with long-term survival. And in fact, they've been shown to do that, not just improvement, but also a normalization in some blood tests in between roughly about 1 in 4 people, I would say. So they can normalize liver blood tests in about 1 in 4 people over the course of 1 to 2 years. Now, at EASL, at the conference that Robert and I were at, we presented some longer term data showing that the improvement and the normalization rate increases even longer over time. So it's not just at 1 or 2 years you reach the full benefit, even longer over time there's more benefit. And certainly one of my team members was showing the same sort of thing with the obeticholic acid. The longer you are on it, provided sort of there is no tolerability issue, the more you benefit from it, the more likely you are to normalize on it. So it's not just 1 year is going to give us all the answers for these compounds. But it's exciting because up until 2015, we had no second-line therapy. Up until a few weeks ago, we had 2 second-line therapies. Now we've potentially got 4 second-line therapies for people with PBC. And yes, they will be tested eventually as to how they will fare as a first-line agent in people who are either intolerant to ursodeoxycholic acid or even given with urso in combination right from the get-go. Those studies will emerge with time.
All right, perfect. Thank you. So we're 22 minutes in, and that's an awful lot of science. In fact, that's probably the most scientific one that we've done so far. I think it's really important. I think it's great that we've recorded it and it'll be on your YouTube. And so patients will be able to go back and watch it again and take the notes and come back with their further questions. So just to defry the brain again, let's go back to a slightly more challenging data-driven question.
Yeah.
Which is, who do you think will get further in the Euros, England or Scotland?
I would say, well, this is challenging because I'm talking to a Scot. I would say England are more likely to, but that's not my preference.
Okay, so I am going to question your data, but so right, okay, that's fine. So what I did, I just wanted to kind of clear the head and just give us a space because we're going to move on now to Monday, because we've just done years and years and years of PBC history in 22 minutes, which is fantastic, but it's a lot of stuff in a very short period of time. So on Monday, there was a very, very exciting announcement. Can you tell us about that, please?
Yeah, so the challenge that anybody has, be that a regulator or an investigator, when they're studying a new compound for PBC or any disease for that matter, is first of all, recruiting enough people into a trial, getting enough people through that trial, analyzing data from that trial to prove that that medication is better than what is currently available, or what is better than not taking that particular drug or that particular therapy. That is one of the first initial big hurdles. Now that was overcome by both companies, and they both showed benefit in terms of improving blood tests and improving symptoms, in fact. Compared to not taking either one of elafibranor or seladelpar. The next challenge is then getting what we would call regulatory approval, and every country or every geographical region in the world has a different set of regulators. So our regulators in the United Kingdom are now different to the regulators in mainland Europe. Our regulators here are different to the ones in the United States, and they're different to the ones, say, in Canada, Australia, the Asia Pacific region, and so on and so forth. Often, because the way the world works, most drugs, when they come to be regulated, will or get regulatory approval, would get regulated in the United States. Sometimes they get approval in other countries. So, for example, we haven't talked about a third one of these PPAR agonists called saroglitazar, which is developed out of India and is currently available for the treatment of fatty liver disease, for instance, and is now being trialed in PBC. So that is another agent that we will soon start to hear about, I'm sure. But that will very likely get approval in India before some of these other compounds. So the point is, every country has a different set of approval processes. On Monday, elafibranor was granted approval by the United States regulators, which we call the FDA, Food and Drug Administration. And that was granted, to my knowledge, and bearing in mind I'm not an American and I wasn't involved in the United States submission, but that was granted approval on a conditional basis, an approval that, yes, we can use the compound for the treatment of people who don't respond to ursodeoxycholic acid alone. There is no reasoning or rationale that that was written in saying they have to try bezafibrate, because bezafibrate is not available in the United States. And I believe so, and Robert, you may correct me if I'm mistaken, there was nothing written in saying they had to try obeticholic acid first either. So anybody who's not responding to urso is now eligible for treatment with elafibranor, but according to the regulators. However, regulatory approval is not the final hurdle to getting it to you, people who live with the condition. We still need to get what we call market access, and that requires a whole other heap of work, such as cost effectiveness, cost utility, cost benefit, how many people are likely to benefit from the compound, setting price points for the medication, and there is a whole other body of what we call health technology appraisal before we can physically start to give it to people, and that is different in every country. Now, in the United Kingdom, we are not there yet with elafibranor or seladelpar. In fact, we are still going through the regulatory approval process here with the UK. I am optimistically confident, that we will obtain regulatory approval here in a similar way to what the United States have granted, and that will probably come in Q3 of this year. Fingers crossed.
Okay, perfect. Thank you. So again, just to summarize it, the new compound, elafibranor, I've not learned or been told how to pronounce its brand name yet. So if anyone knows how to do that, feel free to share that with me. So it has been approved by the regulator, the FDA in the US.
Yes.
But they haven't done the economic negotiation to set a price. So it then opens up access to US patients.
I don't believe so, but I could be mistaken because I'm not physically based in the United States, or I don't work there. But that's my understanding. I think it is easier. It will be easier in the United States because of the way their healthcare system works, and there will be some people who say, right, it's approved. Can my health insurance company pay for it? Yes, or approve it, and can I just get it now? It'll be here in the UK through the National Health Service. I believe it will still have that second barrier to go through in a slightly different way.
Okay, perfect. Thank you. So I know we're stepping away slightly from clinical and more into kind of drug development, but what can you tell us in terms of what are known as early access programs and compassionate use programs? So once a compound is available elsewhere, what do you know about these sort of programs and what they mean potentially for PBC patients?
So early access use programs and compassionate use, there is a bit of overlap between them. Early access program means that the company itself will provide the drug once it has approval, but before it gets market access to a group of people, often being seen or being treated in high volume centers.
Yep.
So, for example, if we have people with PBC who are eligible to receive elafibranor, and we have regulatory approval for that particular compound in the UK, but we don't have it yet delivered in pharmacy. We don't have it approved by the market access committee, and so on and so forth. We can still apply to it, and the company will fund it and provide it to patients. That is what we would call an early access program. Compassionate access use is similar, and sometimes the terms are used interchangeably. But even before if the compound is, for example, licensed for something else, or is or licensed in another country and is likely to be licensed here in the UK, we can apply for that compassionate access use program in a similar way to the early access use program, again funded by the company, but we do not require it to be licensed for PBC or for whatever the disease in question is before we can give it to patients. So an example, so just going slightly off topic here, there is another disease, primary sclerosing cholangitis, PSC, which often occurs in people who've got colitis, inflammatory bowel disease. And there are some similarities to PBC, but it is a different condition. There is both conditions, PBC and PSC, can present with itching, or what we call pruritus. There is a drug that we can use to treat pruritus in a third condition that affects children called Alagille syndrome. And we've applied for what we would call compassionate access to that compound called maralixibat to treat a specific group of people with PSC who cannot take part in clinical trials, who are not eligible for early access program or getting access to any of the other newer agents. But because that drug is licensed in another health condition, we can apply for what we would call a compassionate access use.
Yeah.
With PBC, coming back home to PBC, for elafibranor, we can apply for what we would call early access program once we have regulatory approval for treating certain people who we think would benefit, rather than waiting for the whole market approval process.
Yeah, got you. Perfect. That's really, really helpful. So thank you. The last question is actually one that came in to us now. So I'm going to give you the first live question of the day, which is, can you please tell me, do you think that all of this means that there's a cure on the horizon?
Yeah, well, that's the $1 million question. And it sounds vague and and we're in election season, so I don't mean to sound too much like a politician with my answer.
I've seen your question time.
No, I know. Well, yeah. So, yeah. And whilst Rishi Sunak and I are the same age, we don't share the same views on many things. But when it comes to the word cure, that is very difficult to define. So if we want to define it in the strictest way, wherein you take the medicine for a certain period of time, you can stop the medicine, and you never have to take a medicine for that condition ever again. I think that aspiration is quite far, if I'm being very honest. That's my. I think we are not there yet. If, however, we use the term cure to mean maintenance, wherein we can start to attain normalization in liver blood tests, freedom from symptoms permanently without needing to worry about disease progression at all. So that's perhaps called remission and maintenance rather than cure. I think that target is very much on the horizon, because if you were to talk to Robert and I 5 years ago about medicines that normalize liver tests when it's not clear with URSO, we would think that's something that is very far-fetched. But here we are in 2024, and some of these newer compounds, if you say to them, like, 1 in 3, 1 in 4 people can normalize liver tests. It might take a few years, but you can normalize liver tests. That is something we never thought would be possible. And the fact is that we're getting there. Similarly, if you thought that we are having PBC-specific symptom-directed therapy for these agents, for this condition, we wouldn't. We thought that's never going to happen. Nobody's going to invest that much money, time, effort, willing to support people who have PBC with bad itch, with fatigue, with brain fog. We never thought that would be possible. And I remember there was one meeting that you were not at, Robert, but our colleague David Jones was, and one of our own trial coordinators at the time was asking the question, saying, nobody's going to want to come into hospital for a symptom-based therapy for PBC. It is not something that any trials unit would entertain. It is not something that patients would waste their time and effort for. That was the narrative 10 years ago when I was a trainee doctor. And now that is the norm. People would much rather come into hospital for a symptom therapy that's going to make them feel better than something that's going to improve their blood tests. So I think we are getting there for maintaining people free of symptoms, normalizing bloods, but they would have to continue therapy. I don't think we're there yet, and I don't think we'll get there for another 10, 20 years probably before we can say cure is permanent.
Perfect. All right. Thank you. Again, trying to be as equitable as possible and fair to everyone. I don't remember if we talked about Bezoka or not.
We talk about what? Sorry.
Bezoka.
The combination. The combination. Sorry. Yes.
Yeah.
So that's an interesting topic. So when Robert asked me the question about current second-line therapies, and I talked about bezafibrate and I talked about obeticholic acid, the one thing I didn't mention is the combination. So sometimes we do combine sodioxycholic acid with obeticholic acid and bezafibrate and give all three compounds to people, often in a stepwise way, in a sequential way. There has been a series of publications illustrating that approach is effective and safe in people with early stage PBC without any significant cirrhosis or fibrosis, which is a stage before cirrhosis. So the question then arose, saying, well, why do things sequentially? Could we combine bezafibrate and obeticholic acid right off the bat when somebody's a non-responder to urso? And the answer is yes, we can. And there have been some trial data presented at EASL and the American Liver Meeting equivalent last year as well, showing that when you combine bezafibrate and obeticholic acid right from the get-go, the rate of normalization that you see in people are even greater than you see with the individual compounds, and in fact greater than you see with elafibranor and seladelpar. Now those trials are at an earlier stage than the seladelpar and the elafibranor trials. They will take a bit of time, years, to catch up, and the question has to be asked, well, what if you combine seladelpar or elafibranor with obeticholic acid, with OCA, or compounds that work in a similar way? And one of the drug companies that has bought seladelpar now owns an agent that is similar to obeticholic acid, and I suspect that they are already thinking and planning trials or combination trials in that way. So combination pills, combination therapies will be offered to most people in the next 3 to 5 years, if not already. You muted, Robert, sorry.
There you go. See, I do shut up sometimes. Right. Thank you. Palak, can you take OCA if you're in F4 fibrosis?
Yes, you can. Absolutely. So you can take it. You make sure that there's no what we would call features of decompensation, such as fluid in the abdomen, ascites, no encephalopathy, which is a brain state in a very advanced disease, and no history of vomiting blood, such as varices, which you only get in the very end stages. And importantly, if your doctor feels that your blood tests are safe enough for you to do so. But yes, as a short answer, you can.
Perfect, thank you. I know exercise is encouraged to keep strong and healthy. I enjoy running. Wonder if it's a good idea to really push yourself with exercise when you have PBC. Can it have a negative effect if you overdo it?
The answer is it can't have a negative effect on your liver if you over-exercise, but there is, as with everything in life, that sort of balance between over-endurance and peak endurance and the effects that exercise will have. I enjoy running. I do it every morning, and to this day, and I can't get through my days without it. So I certainly encourage sort of early morning runs. Before you know it, you'll be doing 5-6 Ks every morning, and sort of it certainly improves fatigue. That is evidence based. What I would say is you can't overdo it from a PBC point of view, but it can have negative effects if you on the rest of your body. So certainly don't overdo it if you feel you're pushing beyond your capacity. Do mix up, running with other things. I mean, everybody should have some form of weight training and resistance exercises to help improve fatigue as well, and to live longer.
All right, perfect. Thank you. Are fat-soluble vitamin supplements considered important by clinicians? Actually, what are the fat-soluble?
Yes, absolutely. So the fat-soluble vitamins are vitamin A, which is important for eyesight in particular, vitamin D, which is important for immunity and bone health, vitamin E, which is very much about, again, about brain function and neurology and nerves, and vitamin K, which is important principally for clotting, but also has an immune boost. They all have some immune function. And when you have PBC or any form of liver condition that's very advanced in its stage, and there's different ways of defining advanced, you will absorb less of these fat-soluble vitamins. Vitamin D in particular comes from sunlight, which you get lots of in the United Kingdom for about 2 weeks in the year. And we certainly, as a population, don't get enough vitamin D compared to neighbours in the Mediterranean. And there's a direct link between vitamin D exposure and fatigue as well in general health. So they are considered important by clinicians. I tend to check vitamin D in everybody at least twice a year if they come twice a year, or at least once a year if they come once a year. Vitamin K I also check, but I use a surrogate. I use clotting parameters to see if they're deficient in vitamin K rather than measuring vitamin K directly. Vitamin A is very difficult to measure because sort of well, not difficult. It takes longer for the result to come back, should I say? And I tend to only measure that in people who've got a high bilirubin, who are jaundiced, who've got more advanced disease, because it doesn't tend to fall in early stage PBC or other liver conditions. Vitamin K is the one that's that most UK labs don't let you measure, so that's quite challenging to measure. And vitamin E again is a send away sample that I tend to measure in very advanced liver diseases. So in short, yes, we measure them, some more often than others. Some can become lower very early on, even in the absence of a liver disease like vitamin D. The others I tend to individualize as to how often we measure them.
Perfect. All right. Thank you very much. Are GGT levels and parietal cell autoantibodies relevant in PBC? I am AMA and blah, blah, blah. I am AMA and ANA positive, but not officially diagnosed as yet.
So what was the start of the question, sorry, before you mentioned?
Gamma GT levels, and it says parietal cell autoantibodies. Okay. Are they relevant in PBC?
Sure. Okay, that's an interesting question. To diagnose PBC, we would need to see elevated alkaline phosphatase values and elevated gamma GT, I would argue, in most people. There are some exceptions where your gamma GT can be low or normal if there's a genetic reason for that.
Yeah.
In isolation, if the gamma GT is elevated with the antibodies that have been mentioned, anti-mitochondrial, anti-nuclear antibodies, that by definition would not lead to a formal PBC diagnosis. However, there are a few exceptions to that. I mean, a few exceptions, and that's if somebody has symptoms such as itching in the palms and soles of the feet. So symptoms you would associate with PBC. If for whatever reason that individual has had a liver biopsy and it shows that parts of the liver that are affected in PBC are affected, like bile ducts, then yes, I would classify that person as being diagnosed. But for most people, 95% of people, if you've got a slightly high gamma GT with those antibodies, I would not formally diagnose you as PBC, but I would monitor you. I would either monitor myself or the general practitioner to check all your liver bloods every year to see if you develop an elevated alkaline phosphatase or other liver enzymes before making that diagnosis. Anti-parietal antibodies, I mean, so parietal cells are in the stomach and they're associated with, and if you've got antibodies to them, you can develop anemia. It is not a PBC phenomenon, but it is more common to have those antibodies if you've got other autoimmune conditions. So for this individual, I would certainly say if you have symptoms of PBC, then I would request that you are treated. And if you do not have symptoms of PBC, then I would then monitoring with liver bloods every year, talking to a doctor about symptoms every year is perhaps all you need.
Perfect. Thank you. That's helpful. So we're on steatotic liver disease again. So would URSO help with someone diagnosed with steatotic liver disease and or high cholesterol? Would it help decrease their cholesterol, or does it only work with people with PBC?
No, so there is lots of data. I mean, historically, decades ago, that ursodeoxycholic acid can help improve cholesterol values. It's not as effective as some of the other agents that we've got, though, for treating cholesterol. So that's why it's not used as standard of care. It can help, but it is not standard of care for treating high cholesterol because it's not as effective as other agents that we've got. So it might bring it down a little, but not a huge amount.
Right, perfect. Any information on the suitability of Wegovy or Ozempic for PBC patients? Does it conflict with Urso?
Okay, so Wegovy and Ozempic, these are trade names for a class of compounds, called semaglutides or anti-glucagon-like peptide 1, and these are weight loss and anti-diabetic medications, and these are agents that we use to treat, in some people, fatty liver disease, steatotic liver disease, as it's now more appropriately called, and in the States, lots of people use them just to lose weight. They're very expensive. So, I mean, the last time I checked, one of them, I think it was £12,000 to £15,000 a month, to sort of or dollars a month. I think it was a United States thing that I checked. So a lot of elite athletes use them when they have to lose weight for movie roles and things. They are new compounds in our field. They have been used for a long time in diabetes. And they don't interact with PBC medications. I do not advocate them routinely in people unless I feel that their weight is having a detrimental effect on their health, and they have not been able to lose weight, improve their steatotic liver disease or diabetes through lifestyle measures. And it's very important that we have objective evidence of that. The challenge with these compounds is that they reduce appetite, and lots of people just don't feel hungry and they don't meet their protein intake. And actually, whilst they still classify as being overweight, or if I may use a term, in the obese category, they're very protein deficient because they're not eating. And so we do see negative effects on health. They can cause problems such as inflammation of the gut, inflammation of the pancreas. They can cause some muscle aches, diarrhea. So they're not without side effects, but they're phenomenal compounds that have revolutionized the management of obesity, diabetes, and indeed steatotic liver disease. They're not contraindicated in PBC, but I'm slightly cautious if we're giving them to people who've got very advanced liver disease.
Yeah, I'm with you. Brilliant, thank you. Back to our second-line therapy. So somebody was suboptimal response, started on Biza. After the first month, all LFTs were normal, but elevated ALT, AST. Could that be the visa? What would you suggest the next stages in terms of the conversation with their clinician?
So if somebody is on bezafibrate and the ALT, AST were normal before starting Biza, and now they have become elevated and they haven't become elevated before, I would be concerned that they are related to Biza. I wouldn't stop them empirically if it's just been started. Some people can improve their liver bloods, but if they're still elevated or going up at 2 months, for example, which I know is a long time, or thereabouts, and they're still going up or still elevated, then yes, I would probably want to come down or come off the bezafibrate and try something different.
Okay, perfect. Thank you. Can PBC cause problems with the finger joints of the hand? Seem to get inflamed in the winter and the joints become deformed. Sometimes moving them is a little difficult.
So PBC is an autoimmune condition, and there is a related autoimmune condition that occurs more commonly in PBC than the general population. And that particular phenomenon, or syndrome, shall we say, is called Raynaud's phenomenon. And that can occur with things such as scleroderma, which is a skin tightening condition. It can occur with some things such as dry eyes and dry mouth. But Raynaud's phenomenon, which is sort of sounds like what this individual describes, where the hands become very painful, cold, and can change color over the course of time. Those sorts of things are a recognized feature of Raynaud's, and it occurs more commonly in PBC, as I mentioned, compared to the general population. It is not PBC related in the sense it doesn't go hand in hand with how bad your PBC is or how good your PBC is. It doesn't respond to PBC treatments. It just occurs more commonly because you have PBC than another thing. It is treatable, and it's important that you mention it to your PBC doctor or your GP. They may start you on therapy or like another medication, or refer you to a specialist to try different medicines to try and help with those joint pain, swelling, deformities, and the color changes that you might experience. But it's important don't be silent about it. Please do sort of seek help about it. It's treatable.
Right, thank you. Another person suffering from really bad joint pain, fatigue, started the menopause also, and have been started on Everil Conti patches.
Yeah.
Any information you can tell about those with PBC? Are they any contraindications? Anything we need to know?
Yeah, sure. So it's a frequent question that we are asked, mainly because people with PBC, most people with PBC are going to be women who are above the age of 45, above the age of 50 years old, and that is the time where hormone replacement therapy begins to be sought.
Yeah.
First and foremost, it is not contraindicated to have hormone replacement therapy in PBC. And if you need it, if you want it, if you feel that you benefit from it, ask. And if your GP is not sure, ask your liver physician. If your liver physician is not sure, they should be asking someone like myself or others who have a broader experience of treating PBC. So they are not contraindicated.
Yeah.
Hormone replacement therapies come in different shapes and sizes, similarly to how combined oral contraceptive pills come in different shapes and sizes. So they're not all the same. And Everil Conti patches, is something that you put on the surface. And generally speaking, it is my preference that people are on gel or patch forms of hormone replacement rather than tablet forms. And when people need to have other forms of hormone therapy, such as contraception, they have ones that have minimal estrogen and more progesterone, which is the other hormone content. And that's mainly because sometimes with estrogen replacement therapy or estrogen hormonal therapy, the blood flow can become a bit sluggish in and around the liver. It's rare, it's uncommon, it is not a contraindication, and it is not an absolute that you cannot take these estrogen compounds. But if there is a choice and there is availability to have something that is slightly lower in risk or has a slightly lower chance of causing these problems, then we always go for that. But the short answer is it is not contraindicated in PBC. We have lots of people who are on Everil Conti patches without any problem in our program. And if it's working for you and you are happy and your liver doctors are happy, I'm happy.
Perfect. Thank you very much. This will take you back to the old days. Is everyone with PBC meant to have a biopsy?
So the short answer is no. The vast majority are not meant to and should not have a liver biopsy. Liver biopsies are done in one of three circumstances. One is if there is doubt about the diagnosis. And that can either be because we feel you have PBC and something else, or we feel that you have another condition rather than PBC, and we're trying to differentiate the two. The second group of people is where we feel that your liver disease stage of how scarred or bad it is under or overestimated by other tools such as scans and blood tests. And the third situation is if you're taking part of a clinical trial, and the clinical trial of this new compound or pathway requires a biopsy to see how the drug is working, if it's working, and whether there are differences before and after treatment. So those are the only three circumstances we would suggest a biopsy. But most people should not have a biopsy, or do not need to have a biopsy.
Yeah, all right, perfect, thank you. Now, as you know, we have no favourites here at the Foundation. However, we did meet two amazing physiotherapists. I can't remember where they work, but they've been doing incredible work, and we're looking forward to sharing that through the Bare Facts and doing some Q&A sessions and that kind of thing. So, but on the topic of that, somebody's asking for knowledge, information, support around weight loss interventions and what is best for PBC folks. Do you know anyone that could help?
Yeah, so I mean, so we have physiotherapists who are increasingly interested in liver medicine and how exercise interventions, how certain types of actions, physical actions, can benefit not just PBC, but the symptoms in and around with it, and importantly, the overall quality of life. They are less trained, should I say, or trained's not the right word, but less researched in weight loss per se. That's where our nutrition and dietetic colleagues will work synergistically with them. In Birmingham, we have two, liver physiotherapists who I work with very closely. They're sort of they do a lot of work with our group, and weight loss has not been something that they have focused on. They're mainly interested in improving cognitive function, brain fog, fatigue, and PBC. But we are trying to get them more engaged and more involved at working with dietitians. Well, actually, I shouldn't say we are trying to. They are trying to become more engaged with our dietetic colleagues to try and see what elements can help with sort of with weight loss. So very much watch this space. And it's not, we're not the only ones doing it. I know colleagues in London and Newcastle are doing something similar about how we can help people attain what sort of their sort of target weight goal when they've got PBC.
Indeed. And when we say watch this space, again, they've very kindly volunteered to put something in the bare facts for us, and even do a Q&A, which would be absolutely amazing, which is great.
Yeah.
Last question of the second last question from the lives, if you will.
Yeah.
Anything linking PBC and Parkinson's in terms of symptom crossover, facial masking, slurred speech, shuffling, anything like that at all?
Not to my knowledge. I haven't seen an increased association with PBC and Parkinson's. Both can lead to brain fog and sort of cognitive dysfunction, but I haven't seen any robust data with PBC and Parkinson's per se. There was one study, I can't remember when it was, a long time ago, showing or looking at different associations between Parkinson's and various different autoimmune conditions. PBC was not one of the ones that stood out. It was not more common in PBC compared to other autoimmune conditions or the general population.
Yeah. All right. Perfect. Okay. Thank you very much. So my very, very last question for you is, again, taking you right back down to the start.
Yeah.
Now that we've come home from EASL, we've had a chance to take it all in.
Yeah.
What's the one takeaway? What's the one thing for you that will either inspire you, change your practice, the next generation of questions? What's really fired you up now from that amazing congress?
So I think the thing that really fired me up, and this is not just because we're talking to the foundation and its members today, was actually nothing to do with first line, second line, third line therapy, but it was an initiative that I'm humbled to be involved with, that's led by our colleagues in the Netherlands. And in the era where your hospital appointments are always delayed, there is a drive to finish them quickly because clinics are overbooked, overrun, and we're short-staffed. It was development of what we would call a question prompt list by colleagues in the Netherlands, which I think is the proudest thing that I'm to be involved. I'm not leading on it in any way. The proudest thing I'm happy to be involved with in my PBC career, because this is a tool that when you're newly diagnosed, or even if you've been diagnosed a while ago, helps in the minds of people who live with PBC, saying, right, these are the minimum standard of things. And you can ask the question in your own way, but the topics, the minimum things I should be asking my doctor to get the most value-based healthcare, the most in my 10, 15, 20 minutes with my consultant or the doctor that I see. And my doctor, my consultant, whoever I see in clinic, the nurse that I see, should be able to answer these 10 or so questions about my PBC care each and every clinic visit. And it's not good enough just giving them that list, but taking ownership and taking and empowering yourself as somebody with the condition to ask the right questions from your team so they can give you the right answers, rather than them trying to beat around the bush and talking about things that only they think about. You can talk about the things that you need to talk about. And this is something that we've developed with patients who live with PBC, their caregivers across different countries, and hopefully it will go live soon. And certainly when it does go live, I mean, I'm sure the foundation will do works with the group who have led that initiative about this prompt list and make it available for everybody.
No, absolutely. So we were co-authors in that, and obviously we worked with the PBC Care Bundle as well. And and again, it's about patient empowerment and making sure that not only the clinician but the patient gets the best use of their time. So thank you.
Yeah, great.
All right, thank you, sir. I really appreciate you being here today. It's an exciting time. I know you're busy, but we're so grateful. All right, all the best.
Thank you, guys. Thank you. Bye-bye.